Good morning or afternoon, depending on where you are. My name is Ariel Kramer, and I am joining you today on behalf of the Digital Health Hub Foundation. So let's see here. Slide. Sorry. Okay. You know what I look like. The Digital Health Hub Foundation is a digital health accelerator at the Worldwide Center for Healthcare Innovation. Our largest program is our awards program, which seeks to find the next best, most impactful, and disruptive in 13 categories. This year, we had over 1,500 companies apply, 350 were named quarterfinalists, and now we have our 124 finalist companies. So right now, I'd like to introduce you to Matthew Holt, our executive producer at the Digital Health Hub Foundation and the founder of the Healthcare blog and Health 2.0 conference. Matthew?
Hey, Ariel, thank you so much and welcome everyone. This is one of, I think, 15 or 14 or 17 categories that we're doing. This is an unusual one because there are no rising stars in this category. We just have 4 established companies called the best in class talk about patient safety. We were kind of kidding before this started. The patient safety got a big, big boost in terms of an issue that people cared about in the very late 90s with the IOM report To Err Is Human. And that was the one which said that there was somewhere between, I think, 100,000 and 400,000 deaths every year due to medical mistakes in the US. And we were kind of going back and forth about how much has really changed. Anyway, I'm also thrilled that instead of me sort of being an amateur in this area, and I think if we can go to the next slide, if there is one, there may not be one, that I have with me my colleague, Ariana Longley. Ariana is going to run some of the questions. She's a real expert in patient safety. She spent a lot of time at the Patient Safety Movement Foundation, working with the WHO, and also is now as a patient safety consultant at the Jewish Healthcare Foundation. But before all that starts, we're going to have a quick word from our colleagues at McKinsey about the sort of general strategy. And Sarun, take it away.
Hey everybody, it's a privilege to be here with you all as a knowledge partner. Today, my name's Sarun Charmiland. I'm an internal medicine doc and a partner leading our client work at McKinsey at the interface of payers and providers, innovators, startups who are working together to improve quality, access, and sustainability of healthcare. You may know McKinsey as strategy consultants serving strategics across the value chain, which is true. But you may not be aware that we also serve startups, scale-ups, 1,000 of them globally. And we have an entire practice focused on healthcare, private equity services, and so forth. And second, we don't stop at strategy. We partner for as long as 2 or 3 years, from strategy to launch to execution, jointly targeting and achieving revenue and margin and valuation milestones. So I'll just take 2 minutes to share a brief perspective on this, which is that we've learned again and again that the 10 timeless tests of strategy can also be used to pressure test the strength of strategies of best-in-class folks like you all. We've highlighted 6 of these 10 tests for you to consider, but just to give you a flavor of a few. The first, will it beat the market, is comprehensive. The remainder break down the elements of what a market-beating strategy is. But the first really identifies how is your strategy different and better to avoid the pitfall of just playing along with market forces. The second is around scarce resources. So too often companies and strategies are unclear about the specific special capability that is critical to their success. So the question forces discussion around what is the special sauce? Is it a privileged asset like a patent that can be bought and sold? Or is it a distinctive competency like speed to product launch that still confers a competitive advantage? And the third is about granularity of where, not how, you compete. Where our research has shown that 80% of the variation in revenue growth across companies is explained by choices about where to compete, and the remaining 20% on how they compete. So does your strategy outcompete others by allocating investments to the most attractive subsegments So that's a flavor of a few. As you evaluate strategies, we'd encourage you to ask yourselves, how many of these tests does your strategy pass today? And with that, good luck to y'all. Super grateful for your passion and dedication and impact on healthcare. And I'll hand it back over to Matt and Ariana. Thank you.
Thanks, Varun. Appreciate that. Wise words on strategy from the folks at McKinsey. So now we're going to dive straight in, and we're going to go around in no particular order. Just one I have on my my sheet. I'm going to ask the each of the folks to start off, just to introduce themselves and what their solution is, because some of these are large companies that have done to do multiple things. So we will start with you, George, at Teladoc.
Awesome. Well, hello, and thank you for having us today. My name is George Verghese. I'm a VP of Clinical Quality at Teladoc Health. Teladoc Health is the global leader in whole person virtual care. 1 out of 4 Americans have access to at least one of our products and services, either through their employer or health plan. Our clients include at least 2/3 of the Fortune 100. You know, people know us historically for our virtual urgent care solution or Gen Med solution, but we're, as you alluded to, way more than that. We've got a lot of momentum in virtual primary care. Visits have doubled year over year. We've got mental health, dermatology, nutrition, expert medical opinion. We have over 1 million enrollees in our chronic condition management solutions. And in addition to the care we provide, we also partner with hospitals and health systems. We use our technology to enable millions of virtual interactions each year. And so our whole person care delivery model is really based on addressing an individual's full set of health needs. So instead of just offering access to a hypertension point solution, we focus on how we care for a person living with hypertension, from mental health support, coaching, and even connecting them to the right in-person treatment when appropriate. So thanks again for having us.
All right, George, can you say one word about how that impacts on the category of patient safety?
Yeah, so we have a lot of different types of care that we deliver, but our virtual telehealth services delivered by licensed providers is a major part of that. And in terms of some of the major categories of patient safety, we see some of the same things that are seen in the brick and mortar system: medication errors, diagnostic harm. And so there's a lot more to say about that, but those are some of the things that we see and that we're starting to tackle with some of our innovations.
Cool. All right. Next up, we'll go to Howard at Commure.
Thank you, Matthew, and to the foundation. First thing I want to say is I want to commend the foundation for recognizing that the epidemic of workplace violence for caregivers is a patient safety issue. Commure Strongline is a product, a simple, elegant plug-and-play solution, which installs a network of gateways about the size of a smart plug across an entire hospital or outpatient facility, and provides to every caregiver a badge, which I hold up. It's about the size of a butter patty, the weight of a sugar packet, which enables a caregiver to press the button anytime he or she feels unsafe. 70% of the workplace assaults in the country happen in healthcare settings. 90% of caregivers have experienced, personally observed or experienced workplace violence in the previous month, leading to PTSD, burnout, depression, anxiety, resignations, and feeding into the crisis facing the healthcare industry today, which is staffing challenges across the board. So it's a remarkable solution being widely adopted across the country. I'm a pediatrician and retired 35-year health system exec who was old enough to have been there for to err as human a long time ago. Patient safety front, CMO and quality officer in 5 different health systems. I have never seen anything as impactful as this solution before.
So
Thank you, Matt.
Thanks.
Yeah.
That's great.
Yeah.
When I'm a nurse, I'm a doc, I'm dealing with a patient. Something goes wrong, the patient gets violent. I feel unsafe. I hit the button. What happens next, and what's going on in the background?
So when staff are encouraged to press it early and often, all of the evidence-based literature suggests that de-escalation is the key to success in avoiding these horrendous events. So pressing it early and often simultaneously alerts security, or a PBX operator, central operator at a hospital, as to the exact location of the person calling for assistance. Simultaneously also alerts all proximate colleagues who are also badged. And the secret sauce is getting people in to support that individual who feels at risk as early as possible, backing them out of the situation, the confrontation, and in a worst case scenario, having support there available immediately to assist them in the case of a physical assault.
And you mentioned, obviously, this has long-term implications for the staff safety, immediate implications for staff safety, long-term implications for patient safety of the staff as patients if they go through this good. But what about the patient who might be violent themselves? Is there's presumably some safety issues for them in these situations if your solution isn't there?
Yeah, well, obviously getting support into the situation as early as possible is likely to result in greater safety for the patient who's at risk and for the staff member as well. And what we're finding is that the number of alerts escalate in every organization that deploys this system, but the actual number of physical assaults and injuries is going down. We're starting to see that documentation with the early adopters. So it's achieving exactly what we envisioned would likely be the case, that people will report more often, which is consonant with the goal in the patient safety movement as well. Early reporting and frequent reporting is important, but if you do so, your outcomes will improve. And when you ask the question, there's some hard data available from Press Ganey nationally on the actual impact of staff feeling safer and the impact on quality of care.
Fantastic. Fantastic. Mike from Medcrypt.
Hey, thanks everybody. Can you hear me okay?
Yep.
All right. Yeah, my name is Mike Kijewski. I'm a medical physicist by background. I used to be a product manager at a medical device manufacturer that made big surgical robots that shot x-rays to treat cancer primarily. In about 2014, one of our customers went around to a bunch of different medical device manufacturers and said, hey, we're treating a specific foreign dignitary for prostate cancer. And we're concerned that a specific nation state might have reason to attempt to assassinate this individual. So we looked for cybersecurity vulnerabilities in the medical devices we were using to treat this patient. We found some vulnerabilities, please go fix them. So the short version of the story is that there were a handful of medical device manufacturers that had to spend literally years and tens of millions of dollars building cybersecurity features into their products to protect patients like this one. So my co-founder Eric and I, we started our company Medcrypt in 2016 in an attempt to build cybersecurity tools that would help medtech companies build products that were secure by design. And when we started the company in 2016, we had lots of people asking us, who would ever hack a medical device? Is this a real thing? But the last few years have shown that the cybersecurity risk in healthcare is real. And in fact, just this week, the FDA released their most recent cybersecurity set of regulations. And starting October 1st, which is, I believe, Sunday, we'll start rejecting medical devices that do not have cybersecurity features built into their products. So we're in a really good position to have some great partners at Medcrypt, companies like Johnson & Johnson, Intuitive Surgical, and Dexcom, as well as some technology partners like Microsoft.
I'm sure it's super complicated, but what's the actual thing that you do when they come to when these companies come to you and say, hey, Mike, do this for us?
Yeah, so two real buckets of features that we facilitate. Number one is if you're a manufacturer of a medical device, you need to know what software is on your device and what known cybersecurity vulnerabilities exist in that software. So for example, if you're releasing an MRI machine that runs Windows and it's running an old version of Windows that has a security vulnerability, you need to know that. So we have a set of tools that help a device manufacturer know what vulnerabilities they have. Second, it's really common for medical devices to act on clinical data that they receive from other systems. So if you're an insulin pump and you're getting a glucose measurement from a glucose sensor, you need to be really certain that the data you are acting on is valid data and hasn't been tampered with. So we have a cryptography product called Guardian, which makes it easy for medical device manufacturers to secure the data that they're operating on internally, not just to ensure data privacy, to make sure that a patient's social security number isn't leaked, but to ensure that an attacker can't change a glucose measurement and cause an erroneous amount of insulin to be delivered to a patient.
It's probably not a bad idea to make sure the thing's working well in the first place. Absolutely. Brilliant.
Correct.
All right. Wonderful. Okay. So last and definitely not least, it is Stephen from Muru.
Yeah, hi, Stephen Blocker from Muru. Muru takes the clinical decision paperwork that clinicians follow, whether it's a paramedic on an ambulance or pain management procedures within a hospital, and we turn that into an interactive platform on our app where a provider can ask any type of question and it will instantaneously answer them, whether it's doing medical calculations, figuring out what procedure they should be using in the first place, or anything else like that. Even hospital destination decisions for the ambulance. We started pre-hospital care. I'm a former chief of EMS for my agency, and some of our clients include we're the official app for the entire state of New York, so all 62,000 EMTs and paramedics use us, and that included through all of COVID, even when FEMA ambulances were brought in. And we also have been contracted with the Army and Air Force to enter in all of their pre-hospital care clinical guidelines.
Brilliant, very succinct. All right, Ariana, you know something about this, so it all sounded cool to me, but you should be digging in.
Absolutely, and thank you all. Thank you, George, Howard, Stephen, Mike, for making it this far. We're so thrilled that the Pittsburgh Regional Health Initiative was able to sponsor a patient safety category this year to bring some of you people who have been doing great work in this area to light. As Matthew mentioned, the statistics are pretty grave when we talk about patient safety. And so really happy to be here with you all today. So I do have a series of questions for you. We'll see how many we get through between now and the end. But I'll start first with, there are kind of 5 categories of patient harm that we look at. This is based on the Institute for Healthcare Improvement's global trigger tools and some of the reports that have come out of the OIG in the last few years. And those lead to significant harm, injury, and death for patients. And so I'd love if you could just in a few minutes describe which of these kind of 5 problem categories your technology fits into, the product that you're bringing to the table today under patient safety. And as a reminder, that's medication-related errors, patient care, procedural and surgical errors, infections, or diagnostic harm. So I'll throw it over to you, George, first.
Great, and thank you again. Really excited that we have this forum in this category. So yeah, I think as I kind of alluded to, I think the initial efforts of our now dedicated patient safety teams innovations are in our virtual telehealth services delivered by licensed providers. So of those categories, we're primarily focused on things like medication errors and diagnostic harm. In terms of medication errors, we see the same types of things that you might see in a brick and mortar setting: wrong medication given, the wrong dose, contraindicated meds. Our experts, who really come from some of the largest brick and mortar health systems, observe, I think, Matthew, as you alluded to, while a lot of really important work has been done in those settings, medication errors are still common across all care delivery settings. And there's an opportunity for us to really get further upstream. For example, if someone inadvertently receives a medication that they have an allergic contraindication to, but only as a minor reaction. Well, not a lot of investigation is typically done, but then say that same underlying error mechanism occurs again, and this time a different patient has anaphylaxis. Well, we put a whole ton of resources into that investigation, but we really could have been more proactive with the near miss. So a lot of opportunity to be more systematic, use human factors thinking, and even leverage things like simulation, which are actually way easier in a virtual care environment. In terms of diagnostic harm, something we're definitely also trying to address. As a practicing pediatric cardiologist myself, this one is particularly important to me. When it comes to diagnosis, virtual care is so unique because so much of it depends on what the patient tells us. We're so reliant on them. And so what can we do to best support the patient to get to that critical information that we need to give them the best possible care? And then on the provider side, how do we reduce some of those common biases that lead to diagnostic error? Anchoring bias, for example, right? You come in vomiting, it's probably just gastroenteritis, a bad stomach bug, but it ends up actually being something much more ominous that you didn't consider, an appendicitis, or actually even a pituitary tumor, as a close family member of mine sadly learned the hard way.
Great, George, thanks. And we're glad that you're working on those 2 areas in particular. Howard, you're kind of next on my screen. I'll pass it over to you.
Thanks, Ariana. I'm going to a little twist on the response, since obviously Commure Strongline is not involved in direct patient care. I want to answer the question with the focus on the impact on what does it mean for your staff to feel safe in an organization, when we know from looking at national data, by and large, caregivers do not feel safe right now. When caregivers report feeling unsafe at work, nurses perceive that they have a 52% increased incidence of missed care. When they feel unsafe at work, their enjoyment of their job is 27% lower than staff who feel safe. And CMS star ratings in organizations, quality ratings in organizations where staff report not feeling safe are 22% lower. So critical importance of doing things that allow staff to feel safe. And what this product has done, taking a look at the first dozen or so organizations that deployed Strongline with pre and post survey responses to the impact of giving people this little badge that allows them to call for assistance. 97% of staff are wearing their badge every day after it's been given to them. 99% feel like their organization has made an investment for them to feel safer. And 92% feel like they are better prepared to deal with the complicated situation with the patient when they don't feel safe. I was a health system executive for 40 years. I never got survey results like that about anything that I ever asked staff about. If you asked them what were their favorite ice cream flavors, 50% would disagree with what we served. The point being, high impact for staff to feel safe. And we know when staff feel safer, all of the quality metrics improve in the organization. And most importantly, as I listen to nurse executives who have seen it deployed in their organization, they say that staff behave differently and are much more engaged with their patients, and therefore much less likely to make the errors that result in the statistics that you cited.
Absolutely, Howard. I think that you're 100% on the right track there, because if the health workers feel safe, if they're supported, then that affects all the care that they provide downstream that lead to all of the errors later.
Yeah, one quick anecdote for you. When we were first rolling out the product, after I saw it in development at Jefferson Health System in Philadelphia, a chief medical officer of a children's hospital said to me, how can we expect our staff to do all of the things that we're asking them to do on patient throughput, patient experience, patient safety, infection control, operational challenges, financial, when at their core, they don't feel safe coming to work? And if any of you took an introductory psychology course, go back to Maslow's hierarchy of needs. If you don't address the fundamental need to feel safe, you can't individually achieve your potential, and an organization can't achieve its potential at its primary mission of keeping patients safe. And we have an entire industry right now where staff do not feel safe when they come to work. And we think that our data indicates that Strongline allows them to feel safer and actually be safer.
Thanks, Howard. Appreciate those comments. Right on. All right, Stephen, I'm going to pass it over to you.
Thank you. Yeah, so this is really where we focus a lot, is on clinicians making the right decisions and helping them make those decisions right in the field while they're treating the patient. In a lot of cases for us in emergency medicine, right, especially in the pre-hospital setting, we're talking about those medical decisions being made under a huge amount of stress with a very limited amount of staffing. So in medication-related errors, we have over 1 million searches being done per year for just dosing alone, where someone will say, I have a 7-year-old who's suffering from an asthma attack, first-line medications hasn't worked, even maybe second line, and I have to run an epi infusion. How do I do that given the drip sets and saline bags I have on my ambulance, and how can I combine all that? And Muru just simply answers that question, doing all the med math, helping them make the decision, and so forth. We then touch on the other areas like patient care and procedural things by also not only helping them with the dosing, right, which they can just now ask a question and get right to an actual answer, but even allowing them to understand what differentials they might be missing. So they might not remember which treatment algorithm that something is treated under, but they might say, oh, I think it's covered under this. And then, by surfacing other differentials at the same time, right within their field of view, sometimes they might think, oh, right, although I was looking for this, right, in reality, a different differential I probably should be considering. So that's that piece. And then as far as diagnostic harm, especially under under the significant stress people see sometimes, right? They get blinders and tunnel vision treating, you know, only one of the symptoms they see in front of them. And it's our job, again, to surface as much of that information as possible. A lot of times, as the clinical guidelines change, most providers aren't even aware of it, let alone remember it when they're under stress. And we combat that effortlessly because every time something changes, we're automatically pushing out updates. We're feeding that information to the providers when they ask the question. So Muru's automatically updating with that information right away. And then we can then monitor the decisions they were making, and then even send them emails and other feedback back to them, telling them like, hey, you know, in the future, you should be reviewing this procedure or this protocol, all without ever violating their privacy or trust, so that as they're using the platform's constantly helping them, you know, post and even while they're in the middle of a call, treating it, right? Unlike within a typical QA/QI process where we can only treat things afterwards, right? And correct errors afterwards, we're correcting them live as they're making the decisions in the field.
Excellent. Thanks, Stephen. And fun fact, I actually started my career in the EMS fire alternate care space before coming into this world. And so I know how resourceful this will be for many of the EMTs and paramedics out there. So great. Well, to round out the last one, again, not last and not least, or the last, it's Friday, right? Last but not least, Mike, please address our first question here.
Got it. Yeah. So Medcrypt focuses on getting cybersecurity features into all sorts of devices and software that are used to treat patients. So of the 5 categories that you listed, it's very clear to me how we help ensure patient care in the procedural, avoid procedural errors and avoid diagnostic errors. To give you some concrete examples, in radiation oncology, the space that I come from, generally a patient gets a CT scan of, let's say, their lung because there's a lung tumor. That CT scan is then used as an input to plan a radiation treatment, and a very specific amount of radiation is delivered to the patient. There was a study a couple of years ago that showed that hackers were able to take a lung CT scan and add a tumor where there was not one, or remove a tumor where there was one, in a way that a radiologist couldn't detect. So our software can be used to ensure that when a treatment plan is pulled into a radiation oncology system, we ensure that the CT scan hasn't been tampered with. And then similarly, once the clinician says, hey, we want X number of units of radiation in the lung, we can be very certain that up until the moment that treatment is delivered to the patient, all of that data is secure. But really, cybersecurity sort of touches the substrate of healthcare now, right? I mean, it's very difficult to identify an area of healthcare where computers aren't used in some regard. So we've seen ransomware attacks take down hospitals, which would affect pretty much all of those areas of patient safety.
Wow. I had no idea that hackers could go in there and change CT scans. So you learn something new every day. Very, very useful information, Mike. Thank you. All right, so to move on to the next question, and some of you will have answered some of these questions in parts, so feel free to add on to what you might not have already mentioned. But to go into the second one, patient safety isn't the sexiest niche to go into in healthcare. It's oftentimes been hard to show clear ROI for the CFOs running healthcare systems, and there aren't a ton of incentives tied from CMS and other regulators and groups like that to prioritize patient safety from a financial perspective. So I'd really like for you to just in a few sentences or so tell us why your company is prioritizing patient safety, and we'd love to hear from you. So I'll go in the same order as on my screen. So George, I'll pass it over to you.
Great. Well, let me start by saying that prioritizing patient safety isn't new for us at Teladoc. We've been investing in patient safety and quality before many digital health companies were even conceived, let alone actually existed. In 2019, we established the industry's first and only patient safety organization, a PSO, dedicated to virtual care. PSOs, as most know, are certified by AHRQ, the Federal Agency for Healthcare Research and Quality, provide strong protections that foster an environment where healthcare providers can voluntarily report and analyze safety issues, promote shared learning from adverse events and other incidents. In addition, we've always had a robust clinical quality team that kind of tackled safety issues as they came along. But a few years ago, our chief quality officer recognized the need for a dedicated patient safety team. This is what they do all day, day in, day out. And fortunately, our executive leaders agreed. When our chief medical officer joined the organization last year, within a few months, she had elevated patient safety right up to the level of the board. So all this to say that we're definitely prioritizing patient safety. Why? Well, I think at Teladoc, I think we try to honestly just do the right thing clinically, and investing in safety, learning from errors, and equally, probably more importantly, our near misses is acknowledged to be just kind of part of what you sign up for when you decide to take on the responsibility of delivering care for patients and healthcare, even virtually. So, of course, patient safety is important, in part because these types of events can create risk for the organization in terms of legal, reputational concerns. But more importantly, I think the organization recognizes that we're really at this really important crossroads in digital and virtual care. Patient safety events result in us losing our members' trust. And as others have noted, trust is really the currency of care. And this is still an evolving space where people don't know for sure whether they can trust their health to us or not. And we've got to work extra hard to earn that trust and avoid losing it once we have it. I'd even go as far as to say that I think in some ways the future of this space depends on our ability to do this. And prioritizing patient safety is really then foundational to building that trust.
Thanks, George. All right, Howard.
Thank you. So this product was initially commercialized at arguably the worst time in history to do so, right at the beginning of the COVID epidemic, when nobody had any bandwidth for doing anything new. But as we met with organizations across the board, what we were learning was that there were exponential costs, not just associated with COVID, but the impact of nursing turnover, the expense of traveler nurses, the expense from a patient safety perspective of having a 55% increase in your staffs being covered by new graduate nurses who historically might have gotten a couple of years experience before they ended up covering George's patients in the ICU. You don't, with all due respect, you don't want the new grad there. And what we began to realize is that health systems, because the costs lived in a variety of different centers in the organization, hadn't gotten their arms around what the actual costs of workplace violence were. And to give you just a concrete example, a hospital in the Northeast that we worked with recently with 1,000 RNs, conservatively estimated that their costs related to workplace violence were over $2.5 million per year. It would be a fraction of that to literally protect their entire workforce with a product like Strongline, a tiny fraction of that. And McKinsey had a study for which we appreciate a great deal, that the number one factor cited by nurses in their decision whether or not to stay or leave the current job that they're in is the safety of the environment. So 1 in 3 nurses today saying they're going to leave their current job within the next year. It's unsustainable for health systems to not find a solution for staff to feel safer. And we believe that the Strongline product does that literally overnight by being available to 100% of staff in 100% of the locations across large health systems.
Thanks, Howard. Appreciate that. Stephen.
Thanks. If I had known you were from EMS, I could have just talked about nitro and medical control, and we could have kept it very ACLS for all the docs and stopped. To talk about kind of how we talk to CFOs, right? It's a very interesting topic to cover because when we talk about clinical decision support and how that affects, right, it almost affects every aspect of their costs throughout the organization, right? From their ability to be able to introduce new patient care modalities or new procedures faster and sooner because they have more trust that their clinicians will be able to follow it properly, all the way through kind of the classic example of like a lower liability. But we kind of find one of the organizations we've been working with, we're in final negotiations right now, already did an internal study that found that they were saving somewhere between $25 and $30 million a year just with 4,000 providers by implementing Muru across their organization. And where they found that was in kind of 2 or 3 key categories. One was obviously the liability reduction, right? Showing that just patient decisions are being made better and faster kind of on every aspect. Two was actually in turnover and burnout, right? In the fact that when they're bringing on new people, they can decrease the amount of time it takes to onboard them and mentor them into the positions they're going to be in. And then three was education and training, right? So every time there's an update to the clinical decision guidelines that they have, pulling everyone out of the field, paying overtime and covering it for staff shifts, things like that in order to train them on new ACLS algorithms coming down from the AHA all the way through local policies and procedures is something that is just in a huge cost, right? If we take the pandemic alone, there were pandemic triage protocols enacted in New York, where you would have it would be almost impossible to keep everyone updated on what was happening, massive amounts of liability, and CFOs are still seeing fallout from that now. Versus for us, we were able to implement somewhere around 91% of every single provider in New York City that had Muru, regardless of who they worked for, was able within an hour, had gotten the new protocol, updated themselves on it, and spent at least 30 seconds reading it within that time period. So the impact has just been massive, and we kind of have to identify all those verticals for the CFO for them to get a real global picture of how Muru can help with care.
Great, thanks, Stephen. All right, off to you, Mike.
So I think you're correct in saying that patient safety might not be the sexiest area of healthcare in which to work. I have lots of friends who have started